Mm, YouTube. Right?
Hello, hello everybody. Am I audible?
Yes, sir. Good morning, sir.
Good morning.
Dr. Pragya here, sir.
Sorry, got little delayed because the net was not getting connected.
No issues, sir.
Okay, can I run my presentations from my computer?
Yes, sir. Yes, sir.
Okay, fine.
Yeah, here another Pragya from UNICEF.
Pardon?
Consultant. I'm Pragya Chaudhary, sir. IVCF consultant. Good morning, sir.
Good morning, Pradnya. How are you? I'm
Good,
not
sir.
able to see you, so I couldn't identify you. Or I can also say Vinod Kumarji and Sanjay Kumarji. Hello, everybody.
Good morning, sir. Good
I'm
morning.
Pragya, sir. I'm IVCF consultant, sir.
Hey, Prajna, I know you for last 10 years.
Okay, sir.
Yeah. Okay, I didn't recognize, I didn't know that the notice that you were there because your video was not on.
Yes, I'm only my audio is on.
Yeah, no problem.
Okay, sir.
So how are things, Prajna?
Sir, sir, ಹೇಗಿಲ್ಲತ್ತ sir? Again, sir.
There are two Pradnya, so I have to say Pradnya Giri or Pradnya Chaudhary. Can I just try my presentation? It's coming on.
Yes, sir.
My voice is okay, right?
Yes, sir.
Okay. I'll just share my screen and see. I have sent the final representations to you just now. So maybe you can download them. That should be okay. Or you can just share. Is it seen now? Is the presentation visible?
Yes, yes, sir. Visible.
Fine.
Yes, sir.
Yeah, fine. ठीक है. So I'll just close it. Stop sharing.
Good morning. I am Dr. Praveen. I have joined.
Good morning, sir.
Good morning, sir.
Good morning.
Good morning, sir.
Good morning, Pranjana.
Good morning. Is the voice clear?
Yes, yes. Good morning.
Good morning. Good morning. I have also sent.
Good morning, Saurabh. How are you?
Good morning, sir. I'm good, sir. How are you?
I'm fine, thank you.
Sir, Dr. Sarita has not yet joined?
I'll just call her. Huh?
Okay, sir. Okay.
Just
sir.
call her.
Okay, sir. Sure. Dr. Patra, please just test your voice. एक बार कुछ बोल दीजिए. Good morning. Good
Am
morning.
I audible?
Yes, yes. Loud and clear. Loud and clear.
Okay, good morning.
Pragya, would you just test your voice, please?
Good morning.
No.
Oh, am I audible?
Yes, you are audible. Pragya Chaudhary. Pragya Chaudhary.
Yes, sir. Yes, sir.
Okay, great.
Morning.
Wonderful. 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 So, Dr. Gangal, you have
Yes.
shared two presentations. So, they are in PDF. So, that makes it slightly difficult.
Will it be okay if I play from my computer?
Yes, please, please, please. That would be
Okay, so
wonderful.
I have put up, and I just before you joined in, I have tested both the presentations over here.
Okay, wonderful, wonderful, sir. Wonderful. Thank you so much. And Dr. Sarita would also do it accordingly, right?
Yeah, or I will run the presentation. I just
Okay.
asked her just now.
Sure,
Okay.
sure, sir. Sure, sir. Thank you so much. Dr. Praveen, you would be running your own presentation, sir?
Yeah, I will run.
Okay, sir.
In
Okay,
case
sir.
there is any difficulty, then probably.
Sure, sir.
Dr.
Sure.
Sarita, you will be running your presentation from your computer, or you will want them to?
No, either you can do it or they will do it. You can do it, I think, better.
So you means Dr. Gangal or Dr. Prajna?
Dr. Gangal.
Huh?
Sir, you,
Okay,
sir.
you want me to run your presentation? Okay, fine. Okay, I have downloaded it.
Okay.
I'll just share your presentation. Just check whether it's right or not.
Okay.
Just a minute, I'll share your presentation. You check your voice also.
Okay.
This is your presentation, right?
Yes, sir.
Okay, fine.
Hmm.
Okay, I'll share. Once your lecture starts, I'll share it.
Yes,
Okay,
sir.
I'm stop sharing just now.
Hmm. स्क्रीन वरती बरोबर दिसतंय ना सर?
Oh,
Hmm.
no problem.
Dr. Prajna, we will wait for a little while because we just see around 40 participants. We'll wait. It generally rises within the next, 5-6 minutes. It
Yes.
just rises.
Yes.
So we'll just wait for 5-6 minutes and then we'll start.
Okay. Okay. No issues.
Good morning, Dr. Praveen Kumar. I didn't say hello to you.
Good morning, sir.
ଗୋଟେ ଚେଞ୍ଜ ହେଲେ କଣ କହିଲେ?
Okay. Dr. Pragya, can we start?
Yes, yes, of course, we can start
Okay.
now.
Okay. Uh, Good morning. Welcome all to the second webinar series on public health nutrition. And today we have a very, very interesting, very relevant topic. We would be discussing about infant and young child feeding, IYCF, issues, challenges, and solutions. In fact, this has become more relevant because all of you would agree with me that the COVID-19 pandemic is kind of raging like wildfire across the globe, and it has taken down many, including our brave frontline warriors who have been associated with service delivery to the frontline stakeholders. Having said that, we would also explore in today's webinar a kind of a linkage between the preventive infant and young child feeding and also its relevance in preventing the more serious forms of malnutrition, which is kind of manifested when a child becomes severe acutely malnourished, which is a very dangerous form of acute malnutrition, wherein the risk of death is 9 times more than a normal child. Um, so infant and young child feeding also has its relevance in terms of uh, preventing children from getting into stunting, which is a form of chronic malnutrition because mothers do not feed, and all of these will be kind of addressed by our erudite panel of experts today, who we will introduce as we go along with this webinar. Um, it is all the more relevant that during this time we speak about these two very important facets of nutrition and see what the medical fraternity, what the civil society colleagues, and how the media, they kind of rise up to this challenge for not only popularizing the key messages, but also in terms of ensuring that the households, the individuals, the caregivers, they practice the relevant behaviors. So without wasting much time, may I now request Dr. Prajna Paramita Giri. She is the assistant professor in the Department of Community Medicine and Family Medicine in the very prestigious All India Institute of Medical Sciences, AIIMS, Bhubaneswar. I would request her to welcome the participants and give her address. Thank you.
Thank you, Saurabh. Am I audible?
Yes, loud and clear, please.
Thank you, Saurabh. Good morning, one and all present on this online platform. I'm Dr. Pragya Giri, and it is my privilege and pleasure on behalf of AIIMS Bhubaneswar to welcome you all to this webinar on infant and young child feeding issues, challenges, and solutions, organized by Resource Center for Advancement on Public Health Nutrition, Department of Community Medicine and Family Medicine, AIIMS Bhubaneswar, in collaboration with UNICEF Odisha. Today, we have on this platform eminent speakers who have contributed significantly in the field of nutrition, and their deliberation of infant and young child feeding during COVID-19 is going to be an academic treat for all of us. I'm honored to welcome Dr. Prasant Gangal, pediatric specialist, BPNI Maharashtra, Dr. Sarita Bhagwat, lactation consultant, BPNI Maharashtra, Dr. Praveen Kumar, Director Professor of Pediatrics, Lady Hardinge Medical College, New Delhi, Dr. Binod Kumar Patra, Additional Professor, Department of Community Medicine and Family Medicine, AIIMS Bhubaneswar, to this August gathering on this virtual platform. It is my great pleasure and honor to welcome faculty members, residents, and students from different departments of AIIMS Bhubaneswar and other medical colleges of Odisha as well as all over the country. It is a true pleasure for me to welcome all the media personnel, team members of UNICEF Odisha to this webinar organized by RCPHN Cell, or I would say Resource Center for Advancement on Public Health Nutrition, Department of CMFM, Bhubaneswar. So I would like to begin by giving a brief introduction of this RCPHN Cell, or Resource Center for Advancement on Public Health Nutrition, and describe what it is that we do here. This center is a resource hub with the mandate to provide technical inputs in terms of reviews, assessments, studies, workshops, conclaves, documentation, and media advocacy, which started in the year 2019. In recent past, many media sensitization and thematic workshops have been conducted on different nutrition topics having public health importance. Department of Community Medicine and Family Medicine AIIMS Bhubaneswar has started one-year fellowship program for public health nutrition from October 2019, and it is first of its kind in the state. Fellowship course is offered to, it is an opportunity to current masters and doctoral level students for academic training on public health nutrition. And there are 2 seats for every academic session. We have already 1 fellow in this course, and this year we have taken 1, and another 1 will be coming soon. So modules have been developed for this fellowship course by the RCPHN Cell. And as you know that COVID-19 pandemic has brought about unprecedented challenges to the entire human existence, and infant, newborn, and young children are most vulnerable group, and ensuring optimal infant and young child feeding becomes a challenge as the availability and access to nutritious food choices is limited in this COVID time. With the interesting and stimulating discussions, we can together envisage the solution to the problems, challenges that our future generation would face due to COVID and the after effect of COVID. So I once again welcome you all to this webinar, and I wish you a most fruitful hour with interesting and stimulating discussions. Thank you. And if you have any questions during the presentation, just write them in the question and answer box, which will be taken up for discussion by our eminent speakers. Welcome you all again. Thank you. Thank you, sir. Over to you, sir.
Thank you, Prajna, for very nicely not only laying out the theme for today's workshop, but also helping us understand what the RCPHN Cell stands for and what it does for advancement of public health nutrition for the state of Odisha. Now, may I call upon Dr. Binod Patra. Dr. Binod Patra is the additional professor cum additional medical superintendent in the Department of Community and Family Medicine, AIIMS Bhubaneswar. He is also the Associate Dean Research. Dr. Patra has worked as a primary care physician for more than 20 years and managed chronic non-communicable disease patients at the primary and the secondary level healthcare using evidence-based interventions. Alongside, he was involved in capacity building of frontline health workers in surveillance of non-communicable disease risk factors. He was also a part of global prospective urban-rural epidemiological study, the PO study, and contributed to the research therein. He was instrumental in establishment of a non-communicable disease prevention clinic at his present workplace, which has catered to more than 4,000 clients over a 12 months duration. He has more than 50 publications in international and national peer-reviewed journals, and he is a recipient of several prestigious national and international
Saurav
awards.
will start, right?
Yes.
Okay. So thank you very much. Good morning, Saurav. Thank you, Saurav. Thank you, Pragya, and welcome the panelists, Dr. Sarita, Dr. Gangal, and Dr. Praveen Kumar. Am I audible to everyone?
Please go ahead. You are audible.
Yeah. So there is a disclaimer before I start. I have 5 minutes and I will take less than that because already we are running behind. So a disclaimer is I have worked very little in this area, IYCF. So this is an opportunity for me to do a quick review and put my views. My views are always, it has to be taken not very seriously, but it will at least stimulate many of you to think. So when I started looking at this breastfeeding, I remember when I started as an intern, we used to, as a medical student, sometime my pediatrics professor asked us to celebrate breastfeeding day, 1st August, if I remember, in 1995. So sometime 30 years back, 25 years back. And from then, there was a question to me, it's a so natural phenomenon, why to celebrate this week, day or week? And it was that time, it was a day. And why to celebrate that? Then things were little clear, and as we moved along the trajectory, this is something which gets priority during that particular day or particular week of the year within the hospital. So looking at this whole issue of IYCF, which has a history behind it, is breastfeeding. So breastfeeding alone is the single most preventable thing in the world for child mortality. It outsmarts any other intervention, whichever medical intervention, and it's a natural intervention. Complementary feeding just follows that, and it's also one of the important ways how we can reduce the child mortality, whether it is infant or neonatal child mortality. What we have to look is, when we look at missed opportunities, we look at over a period of, when I am just putting things into perspective, when I passed out as a medical graduate, and following that, there is a significant improvement of antenatal care coverage in the country, which is quality antenatal care, I can't say, but quantity antenatal care is something hovering around 80 to 90% across the country. Institutional delivery is another medical intervention which has rose more than 90% across the country. On an average, we can't say isolated pockets will be there, but on an average. But when you look at early initiation of breastfeeding, which is lagging behind, when you have 90% hospital deliveries, early initiation breastfeeding is something around 60 to 70%. So there is something which we are missing during the continuum of care. When we look at DPT-3 coverage, it is around 70 to 80% across the country. But exclusive breastfeeding is something around 50% in the country. So somewhere we are lacking, because this is something, a biological thing, something, a physiological thing, and the intervention is most of a behavioral intervention. So my submission would be to think about it, where we are fluttering, and my colleagues, Dr. Sarita, Dr. Gangal, and Dr. Praveen Kumar will be talking something more on this. The story started long back. It's from human race, from the beginning of the human race. People know the importance of breastfeeding. There is nothing more about to say. But in 1990 was the year of watershed movement for the whole world. And then in Italy, Innocenti Declaration, which talked about protection, promotion, and support of breastfeeding. And from 1990, we were very quick to, in 1992, we enacted IMS Act, Infant Milk Substitute Act, 1992. India is one of the first countries to put regulatory framework in place. Implementation is a challenge. The year 2000 was for the Millennium Development Goals, which again fueled the breastfeeding promotion, complementary feeding, ideals, complementary feeding, starting of complementary feeding. And 2005 is another declaration of Innocenti Declaration of IYCF. And 2003 was the year where global strategy for IYCF was rolled out. So when you look at the history, we are in 2020, and whole thing started in 1990 and it is 30 years of breastfeeding promotion. IYCF promotion is almost 18 years. Where do we stand? If you look at the NFHS data, the breastfeeding initiation within 1 hour of birth is 41%. Less than 50% people initiate breastfeeding within 1 hour. Exclusive breastfeeding, just little over that, 55%. Complementary feeding within 6 to 9 months is 42%, abysmally low. Something which we have to think about. When we look at some behavioral interventions, this is when then there are two ways we can look at. One is health promotion, the other is legislation. We are working at both fronts. We have a legislation in place which restricts commercial forces, that is infant milk substitute production, supply and distribution chain. We regulate that. But are we doing sufficiently on the promotion part? Interestingly, when I looked at the data for Odisha, the things are within 1 hour of initiation of breastfeeding is little higher, 68%. Exclusive breastfeeding is 65%, again 10 points higher than the national average. Complementary feeding is again higher, that is from 20 points higher than the national average, 66%. Just I was thinking, Odisha being one of the laggards in infant mortality, child mortality and maternal mortality, doing better than other national average for the IYCF indicators, core IYCF indicators. More importantly, whether we have sufficient food security, nutritional security for all individuals in Odisha. The question rises, can we make it for the next 5 years, whether 2025, which will be 35 years, or make it a universal phenomenon? There is no medical condition which there are some issues which come up in the last 4 or 5 years. There were consensus development for HIV/AIDS and breastfeeding. Complementary feeding, something which has to be looked at with whether with the right quantity or quality we are doing it, or we are not doing it of the right quantity. And there are some core indicators. There are fortified foods are there, blended complementary feeding is there, or food security for insecure people or vulnerable population is there. So I've put my thoughts with all of you, whether are we doing enough for promoting IYCF in general, specifically for vulnerable population, whether we have programs or we have our things in place to protect vulnerable population. My colleagues will be talking about in specific situation like COVID, and Dr. Gangal will be talking about complementary feeding and IMS Act. He will be talking about the legislation arm of it. Dr. Sarita Bhagwat will talk about the promotion arm of IYCF, and Dr. Praveen, who is a pediatrician at distinguished pediatrician at Lady Harding, will talk about the importance of. He will talk at the medical part. All the we say 2.5% on right side, that is severe acute malnutrition on the right extreme. What I work is something is chronic diseases, where we look at not the severe acute malnutrition, we look at overnutrition, which is also is equally benefited with IOSCF practices. So I leave all of you, I thank all of you for joining, participating in this important discussion. Put your questions, as Pragya has already told, and I leave you with the thoughts whether we are doing enough on the promotion part or legislation part, or something new has to be done. There are many innovations for breastfeeding, and a lot of trainings, and the new modality is we have lactational counselors, we have people who specializes in lactation and young child feeding practices, whether they are sufficient, or do we need to think out of the box something beyond these two approaches? Thank you, one and all. Saurav, I'm done with my sharing with my thoughts, and I think Saurav or Pragya can take it to the next.
Okay. Thank you, Dr. Binod Patra, for your for sharing your thoughts with the group. Definitely, it will provide as food for thought we will look into during the course, not only during the course of this webinar, but also beyond on some of the points and very relevant points that we have raised. Now, it is my pleasure to introduce Dr. Prashant Gangal, who is MD DCH and has done his lactation counselors international course IBCLC. He is from Mumbai. He's a practicing pediatrician and a breastfeeding advocate and trainer. With more than 30 years, he has been associated with this particular field and as an advocate. He is a mother support and training coordinator for the Breastfeeding Promotion Network of India, BPNI Maharashtra. He is a coordinator of the Mother Support Working Group of World Alliance for Breastfeeding, WABA. He's a chairperson in 2018 for the Global Collaboration Committee of International Lactation Counselor, ILCA. He supports projects like Mother Support Groups, Malishwali Training. He has developed, he has been actively contributing in breastcrawl.org, the Hirkani Room and the 4D Clinic. He will be sharing his experiences of doing these during his deliberation. He has coordinated training of more than 60,000 functionaries, professionals in 7 states of India, including Odisha. And you can see more of the BPNI Maharashtra activities in bpnimaharashtra.org, and he has also developed an app which runs on Android called the Shishu Poshan app. So I would request Dr. Gangal to kindly make his presentation. Over to you, sir.
Thank you, Sauravji, for the introduction. Dignitaries and delegates, let me at the outset thank UNICEF Odisha and AIMS Bhubaneswar for inviting me for this particular talk. Am I audible and is the screen well seen?
Yes,
am
sir,
I audible?
Yes, sir. Yes, sir. You are audible
Yes, sir.
on the screen. Yes.
Okay. Okay. So my topic today is IYCF during COVID-19 with focus on complementary feeding and IMS Act. The degree which Saurav mentioned, IBCLC, International Board Certified Lactation Consultant, there was a purpose for me to put this degree over here because I feel that more and more people should get international accreditation across India, and maybe over a period of time, we have to invent our own degree. The governments, the state governments and the central governments have to come out with a curriculum like optometrists, radio assistants, etc. And we need to develop this particular qualification in India. I give my slide credits for this particular presentation to Swati Temkar, who is also a lactation consultant with us. Sauravji has already mentioned about bpnimaharashtra.org, breastcrawl.org and Shishu Poshan app. Please visit these particular sites and you will find a lot of information over there. Let me start by praying to Lord Ganesha. And I like this particular image where young Ganesha is seen being fed by Mata Parvati. And let us invoke the blessings of Lord Ganesha before this presentation and before this particular workshop. COVID-19 has posed challenges for everybody as well as for IYCL also. So we have to practice safe complementary feeding. Continue to breastfeed, provide a variety of foods and regular meals, give healthy snacks and plenty of water, avoid manufactured baby foods and formula milks, and cook at home. Let me be very precise. The recommendations have not changed. We have to take precautions. So it is not correct to say that because of COVID-19, that mothers and babies have to be separated and that the babies have to be given formula milk. That is not correct. So let us start on this particular theme. Proper infant and young child feeding. Why proper nutrition is required even in COVID-19 times? Because proper nutrition ensures healthy growth. It strengthens the immune system, improves cognitive development, and reduces the risk of getting ill with infectious and chronic diseases, including COVID-19. So proper nutrition is a must. Today, my talk is about breastfeeding and complementary feeding, but complementary feeding in particular. Dr. Sarita will refer to the breastfeeding situations. So let me start with the most well-known parameter or indicator of complementary feeding, minimum acceptable diet. It is a composite indicator which combines minimum meal frequency, which we'll come to, and minimal dietary diversity. Percent of children who have achieved both in Odisha as per NFHS 4, 8.9% for breastfed children and 5% for non-breastfed children. Ideally, these figures have to be 100%. These figures are dismal, not just in Odisha, but all over the country. Practice safe complementary feeding. Now, this is refers to the frequency which I referred to. Between 6 and 9 months, complementary feeds have to be given minimum 2 number of times. So maybe either breakfast and lunch or dinner during the family meal times. Between 9 to 12 months, minimum 3 times. However, the quantity of food will increase a little bit. And between 12 to 24 months, minimum 3 times. So definitely breakfast, lunch and dinner, and maybe 2 additional times at around 11 o'clock and 5 o'clock in the evening, when it is tea time for adults. Some complementary foods and snacks can be given. So feeding of young children, a diverse diet is necessary. Dietary diversity is important for immunity. Dark green leafy vegetables, vitamin A containing orange or yellow fruits, and grains and proteins. Sufficient water after 6 months of age. Avoid excessive sugar, fats, and salt. It is important for good immunity, which is so very important in COVID times. Let me come to dietary diversity, which is a very important parameter now and getting more and more significance than minimum acceptable diet. Previously, we used to talk about 7 food groups, but recently we are talking about 8 food groups. Breast milk, the one blue square, has been newly included. We have 2 types of grains, cereals and pulses. Cereal group also contains roots and tubers, and nuts and oilseeds are included in legumes group. Vitamin A rich vegetables and fruits, other fruits and vegetables, and milk products. So standard thali which we have in India, rice dal in the center, maybe roti replacing the rice. On the left side there is a salad. On the right side there is vegetable, and outside there is buttermilk. Non-veg eating people can also have eggs and flesh products included as the food groups. So total 8 food groups. BPNI Maharashtra, for the sake of convenience, added 3 more which are at the bottom. We call it CID. C stands for vitamin C, I stands for iron and iodine, and vitamin D for sunlight. Minimum dietary diversity, MDD. Children between 6 and 24 months of age who have received foods from at least 5 out of 8 food groups, including breast milk is included during the previous day. And the total number of children between 6 and 24 months comes in the denominator. So this is the most important parameter indicator now. Do we follow minimal acceptable diet or we take minimal dietary diversity? MDD replaces minimal acceptable diet as the reporting parameter. So this is the new change which has occurred, which we have to remember, which is very easy. Out of 8, 5 or more food is consumed. Yes, it is the minimal dietary diversity satisfied. That is good complementary feeding. Washing of hands and general hygiene, again becoming very important with COVID. And of course, even without COVID also, we have to practice all these hygienic parameters. Now the important question and the focus of my talk, complementary feeding is so very important starting at the end of 6 months. But do we have a system in place where this is really monitored or explained to the mothers? And the answer is no. At least the exclusive breastfeeding rates are hovering somewhere around 60%, initiation hovering around 60%, but complementary feeding below 10% because we don't have any monitoring system and any auditing system to what mother is giving, whether you take public sector or private sector. And the purpose of today's talk is to introduce the concept of diet audit sheet or 4-dimensional immunization clinic, or you call it in the Anganwadi, you can practice it. You can practice it in the home visits. So what are the 4 Ds? The first is diet and growth monitoring, not just the diet audit, but growth monitoring and linking both. Development. How do you pick up early mental retardation, cerebral palsies, autisms? Drugs. Who checks whether the mother is taking calcium and iron post-delivery? Who checks that she goes for contraceptive measures? Who checks that she gets some medications after immunization for child getting fever and other things? So these things also have to be discussed. And the last thing that comes is vaccination. So I believe that before the last year dose, first 3 need to be practiced very well. And if we start doing it, then the complementary feeding figures will come up. If you are in the Anganwadi, you can forget the dose. Of course, Anganwadi also the vaccination is done, but otherwise also, there are about 60 children in each Anganwadi approximately. So even if the Anganwadi worker takes diet audit of 2 a day, then in a month, all the children would be covered up. During home visits, just the diet and growth monitoring can be discussed along with development. So D1, which we have discussed, D2 development, D3 drugs, and D4 immunization of the baby. This is the diet audit sheet. I'm sure that will be difficult to appreciate each and individual column. There are vertical columns, as you can see, 1, 2, 3, and 4, and an individual square, which I will discuss. So when to start complementary foods? So when the mother started complementary foods, before 6 months, 7 months, 8 months, 9 months, what the mother has done, that has to be written over here and filled up in the sheet. So we expect in the 7th month. If the child is just 3 or 4 months and she is on exclusive breastfeeding, then we need to inquire that when is she planning to introduce complementary foods and direct her thinking for future. Is she breastfeeding now? For example, a 1-year-old child comes. If she's feeding, then you have to indicate how many times. If she's not, then how long the baby was breastfed. Is the baby getting animal milk? What is the dilution? If the powder milk is being used, how much powder is being added to let's say standard 30 ml of water, and how it is being fed. Once we understand these parameters, we can accordingly counsel the mothers. Of course, bottle feeding is prohibited, and we see to it that baby continues to get enough breast milk between 6 months and 2 years. It is not that the breast milk quantity keeps on reducing as the complementary food increases. That is wrong. As the till second birthday, baby keeps on getting quantitatively the same amount of breast milk as the baby getting at 6 months, and between 2 years and 5 years, baby gets something like a tonic, maybe 3 or 4 times in 24 hours. So this particular column has to be filled up. How food is being offered, not just what food, but how it is with family. We expect answer yes. With songs and stories, yes, that's our tradition. Mobile TV, tablet, no. Force feeding, no. That is wrongly marked over here. We don't expect the mother to give forcibly to the baby. These are some not the expected answers have moved. The baby has to eat with the family with song and stories. No mobile, no TV, no force feeding. Sitting at one place, yes, but a baby will move from one family member to other, and everybody can enjoy feeding the baby. Who gives also is important. There is a difference between mother giving and a mother in the creche and the lady in the creche giving. Love is important while giving food. So how food is being offered is important. This is the commonest way that a complementary feeding is given, but this is not correct. This is force feeding. The baby has to sit on somebody's lap and eat along with the family members. So this also has to be inquired. Baby is eating with the family. Hygiene, the fourth point, extremely important. Do we really check nails of mothers and caregivers? Do we inquire that the brushing of teeth is being done? All this has to be included and inquired during diet audit. Clean water, how is the hygiene of water maintained? Are the vegetables cleaned properly? The raw foodstuff, which are they cleaned properly? So this is the last square of column 1. Then the fifth square, we come to diversity. Food groups, we already discussed various food groups, and we should take the diet audit in such a way that we know that how many food groups have gone in last 24 hours. So we know whether the diverse diet is being given or not. So to include maximum food groups, mothers can be taught. There are traditional dishes for each region. I'm sure in Odisha, there are many traditional dishes for breakfast as well as for lunch and dinner. So how to enrich those particular items, that also has to be focused. Again, food, though it is shown in the by spoon over here, ideally it can be fed by clean hands. Spoon, etc., can be only be used. Of course, we don't recommend liquid items, but suppose water is being given, that also can be given directly by katori. Spoon is rarely required. Clean hygiene, of course, has to be maintained. Frequency of food. Again, we have discussed this particular topic, but during the audit, the inquiry tells us, again, the timing is very important. Now in urban populations, children usually wake up around 9 or 10 o'clock in the morning. Then they either miss the breakfast or they miss the lunch. So waking up at proper times, sleeping at proper times is also very important to maintain a good balance of adequate nutrients. Again, different items in Maharashtra have been shown, but I'm sure Orissa has got their own items of their own choice and own culture. So they should be promoted. No separate food to be made for the baby. No rice water, dal water, soups or juices. Food should be softened by spoon or hand in the thali and not by mixer or grinder. Softening of food, one can use breast milk, dal. After 6 months, outside milk can be used for softening the food, or fruits can be used, or curd can be used for softening. So that inquiry also has to be made. Quantity, how much quantity is going in each meal? The meal quantity increases from few spoons at the start of 6 months, at the end of 6 months, to more than a katori in the second year. Child eating should be promoted to eat with own hands beyond 1 year of age. That also has to be told. Vitamin deficiency should be checked, starting from the eye to the gums to the tongue to the goiter and the bleeding of vitamin D deficiency. All these have to form a part of diet audit. Even parents can be taught about it. Nutrition during illnesses, baby wants more breastfeeding, that has to be told. The delicious dishes should be offered, easily digestible, can be given to the baby. The local items can be brought in over here, and extra meals after child comes out of illnesses. No junk food, of course, that has to be also inquired. You'll be surprised to know that majority of population in slums, even in good class populations also, they survive from breakfast on biscuits and haris and toast. So that also has to be counseled to the mother. I'll go to my second presentation. The focus of this particular presentation was to promote the medical colleges and the institutes like UNICEF to find a way in which the mothers can be reached for explaining complementary feeding and how the audit has to be maintained. If you go along with vaccination, the proper timetable will be maintained. I'll go to my other presentation. One of the most important things that occurred was the IMS code, which came in 1981 by WHO and UNICEF. And in 1993, the IMS Act came to India. And let us peek into the IMS Act, and then I will come to the most important point, which I will illustrate now. I will not be just talking about IMS Act. I'll be also sharing that how this IMS code came into existence. Just like the freedom struggle, we know that we are enjoying the benefits of freedom. But once we know that so many have become martyrs for the freedom, for getting that freedom, we get more motivated to enjoy its benefits as well as to carry out our responsibilities. The provisions of the IMS Act, all forms of promotion of baby foods under 2 years of age are banned. All advertisements in any media, we don't see advertisements of baby foods and cereals on TV or any other media. Gifts and free sample to mothers and healthcare providers are banned. I'm showing you what is banned. Donation of IC material, equipments of baby foods, those also are banned. Pictures of the mother or baby or graphics on the labels is banned. Sponsorship or displays in healthcare system is not allowed. Payment of commission to staff for promoting sale is not permissible. So in essence, any direct or indirect help or promotion is avoidable. The only thing that is permitted, again, don't misunderstand. If the infant milk substitute is required, it can be prescribed by the medical fraternity or healthcare providers. The proper information about these products can be given to healthcare providers, but no promotion at all. One of the most dangerous things I find nowadays is that the powder milk tins or baby foods are provided in emergencies freely, and everybody welcomes that. Oh, such a rich donation, the young babies will need it. But that is absolutely wrong. Under IMS Act, that is also prevented. The state authorities and the UNICEF should keep a watch that during emergencies like floods, cyclones, or now COVID-19 epidemic, the IMS producers and distributors do not bring in these products. They are only strictly monitored. They shouldn't have a free hand for distribution, because often in emergency you find the tins of milk, etc. distributed rather than promoting the mothers to breastfeed or providing safe havens for the mothers. So let us go into the provision that why we have to be so cautious about the infant milk substitute companies and baby food companies coming into such emergency situation, show that they are donating something good, but at the same time causing great harm. So let us start with the history. There are again different sections of the IMS Act. You can read IMS Act on the net, but let me come back to why IMS code has come and why we have to be so careful. Pre-1960, let us see what happened before 1960. The change of culture. We started from agricultural type of community, society became industrial 300 years back. As the industries came into picture and urbanization occurred, the joint families broke into nuclear families. Health system changed from preventive to curative. The delivery which was occurring at home was brought to the hospital, so our responsibility is more now. And feeding had changed from breastfeeding to bottle feeding. So this change of culture had changed not just our lives, even feeding practices and the delivery practices. The mother who used to get delivered in sitting position is now getting delivered in lying down position. So what were the marketing strategies which were employed by these various companies? First thing they said was that formula was not just for special situation, but for babies in general. To create market, replace breastfeeding with bottle feeding. Because once you introduce bottle feeding, attained milk is easier. The promotion becomes better. And selling ideas, not just the products. What were the ideas that were sold? What were the myths that were created by these formula companies? Artificial milk is as good or is better than breast milk. Formula and bottle feeding were projected to be clean, safe, medically endorsed, and modern. They also said that they can liberate women from tedious homebound tasks of breastfeeding. Hence, it will be easy to go out work and earn money also. Mothers made to believe that were giving best to their babies, even though they were giving formula milk. Bottles and formula were developed in the developed world, and then they were pushed into the developing world. Sweetened condensed milk was the first thing to come, which we now use to prepare sweets. Then the dried skim milk came into picture. And dried skim milk was shown as a boon to cover the imaginary protein gap. And even UNICEF fell for it. And tons of dried skim milk was brought in. But later on, everybody realized their mistake. It never cured malnutrition. Sweetened condensed milk induced the cycle of diarrhea, protein energy malnutrition, and death, which prompted Dr. Cecily Williams to speak on milk and murder for Rotary Club in 1939. From 1960 to, so one voice talking out before 1960, between 1960 and 70, link between unethical marketing and formula bottle feeding and diarrhea and protein energy malnutrition and infant mortality was realized by many. The marketing techniques were exposed. Dr. Derek Jelliff, who coined the term commerciogenic malnutrition and bottle baby sickness. Dr. Michael Latham and Dr. Catherine Venen also raised their voices. They are well-known experts. Example of messages. See what messages were given by companies. Mothers, believe in lactogen. All things in mother's milk are also present in lactogen. Mothers, watch the health of your baby and give him the best, give him lactogen. Marketing techniques from 1950 to 1980 were many. Milk nurses, they were trained or not trained, promoted value of powdered milk in home visits, clinics, and hospitals. Can you imagine a nurse in the uniform going around in slums and talking about breastfeeding at the same time saying, in case your milk is not enough, please use this. And you can realize what effect it can create. Between 1970 and 1980, public protest became commonplace. Individuals and organizations joined hands, and WHO and UNICEF began to get involved. 1973, the New Internationalist is a well-known magazine. Pediatricians Hendricks and Morley were interviewed, and they said how the malpractices are occurring, how wrong promotion is occurring. NGOs wanted more evidence, and in March 1974, the film Baby Killer was made by Mike Müller in Germany. 1974, Nestle kills babies. That was German translation of Baby Killer. Nestle filed a case. It won the trial, but lost the battle because everybody came to know that wrong techniques were being used. Nestle was warned. This generated huge public attention and media coverage. Stimulated international links, and in July 1976 in Switzerland, many NGOs came together to form a loose informal network. In 1976, Bristol-Myers case in USA, this was followed of Nestle trial. Not just one company, many companies were involved. So Bristol-Myers agrees to stop mass media advertisements and removal of milk nurses. Bottle Baby is a film made in Kenya in 1975. If anybody can get a hand, please send a copy of this film to me. I want to see. A crucial role in initiating first Nestle boycott. There are two Nestle boycotts which occurred where all Nestle products, including coffee, were banned because they were following wrong techniques. In 1977, first Nestle boycott. In 1978, Senator Edward Kennedy got involved, and in 1979, WHO and UNICEF held first international meet for developing a code, and it was agreed that no sales or promotion to public, no use of health facilities, and no promotion to health personnel except factual and ethical information. And WHO and UNICEF to develop international code. IFAN, the Joint Loose Network, became an organization for International Baby Food Action Network. You can go to their website, and it was NGO history in the making. between 1990 and 1990. International Code of Marketing of Breast Milk Substitutes, excuse me, was passed in 1981. It was the first international code regulating multinationals. USA industry made it would have been much better. 118 said for the vote, 3 abstained, and no from USA. Anyway, this is the last slide on my screen. So there are various ways in which the different countries are monitored. We need not go into the details. The message I would like to give you is that please, before you meet the medical representative, or before you any person approaching you for a webinar, any person approaching you for any meeting, please inquire whether the conflict of interest parties, not just the baby food and milk manufacturers, but also the accessories like pumps are involved. Please abstain from them. Please do not accept donations of infant milk substitutes or baby foods for emergencies unless it has been properly regulated. The first responsibility in emergency, including COVID-19, is to support mothers for exclusive breastfeeding. You provide them safe havens, provide them all possible help. Of course, sometimes the help might be required, but that should be under strict regulation of the organization, state government, or UNICEF. So no free gifts, no direct or indirect help from companies, and we commonly see these things occurring around us. We must contact our colleagues and make them refrain from such particular opportunities. Thank you very much.
Thank you, Dr. Prashant Gangal, who is a vociferous advocate for breastfeeding and, in fact, infant and young child feeding, I would say. Thank you so much for giving us your views, and I'm sure if participants would have questions, and they would also kind of keep on sharing their questions with us, which will be answered at the end of today's session. Now, may I take this opportunity to introduce Dr. Sarita Bhagwat. Dr. Sarita Shekhar Bhagwat is a lactation consultant, and she is a national trainer for infant and young child nutrition, IYCN. She is a mother support group leader. She is the past president of BPNI Maharashtra and the recipient of the prestigious Dr. N.B. Kumta Award in 2019. So she will be speaking about the BFHI and its implementation with special reference to the mother support groups. Over to you, Dr. Bhagwat.
Yes, sir. So it's just 5 minutes to 12, so I can say good morning. Am I audible, sir?
Yes.
Hello?
Loud and clear. Please go ahead.
Yes, thank you, sir. So I thank the organizers from AIMS Bhubaneswar and UNICEF for giving me this opportunity to interact with you all. Thank you so much. So as it is mentioned, Baby Friendly Hospital Initiative. Sir, for next slide. Yes. So this in 1989, the previous one. Yes. In 1989, WHO and UNICEF published 10 steps to successful breastfeeding that maternity services should implement to support breastfeeding. And in 1991, as Sir mentioned, Baby Friendly Hospital Initiative was launched to implement 10 steps in the maternity hospitals or facilities. And to comply these steps, whoever will do that can be certified as baby friendly hospital. Next. So what's the aim of this baby friendly hospital initiative? Is to implement 10 steps and stop distribution of free or low cost breast milk substitutes to health facilities. It's very important. It was updated in 2006 and relaunched in 2009, in which it included HIV also and mother-friendly care. Almost all countries have implemented at some or the other time, but the coverage has been low still. And very few baby-friendly hospitals would sustain that status over time. Because as you know, it has to be reassessed every 5 years, not just once you get the certificate and it is called as baby friendly. So reassessment every 5 years is also important. Now in 2017, okay, WHO estimated that only about 10% of babies in world were born in baby friendly facility. That is, the number is very, very low and alarming. Next. So what is the role of this maternity services in breastfeeding? Of course, this is a critical period. Any obstetric problems or intubations, C-section, vacuum, whatever you use in interrupt normal labor, that is going to affect breastfeeding. It's a critical period. If frequent and prolonged contact with mother is not achieved, then there is a greater chance of failure of achieving all parameters of breastfeeding. Good skin to skin contact, of course, leads to good oxytocin release, the love hormone, for the bonding to happen. Initiation of breastfeeding is called nowadays as a third stage of labor, which should be treated as fourth stage of labor, and it directly affects establishment of lactation. We always say जिसकी शुरुआत अच्छी होती है उसका अंत भी अच्छा होगा. So which starts well, it continues well and ends also well. So if good breastfeeding practices are implemented right from the beginning, the chances of successful breastfeeding increase a lot. Major breastfeeding problems occur in first few days of life only. So when mother is likely to be under your supervision at maternity services, and right guidance should be given at that period, crucial time. It has a great impact not only on early neonatal mortality, but also on late neonatal mortality, infant mortality rate, U5MR, and future health also of the babies. So let us just read the 10 steps to successful breastfeeding, which have been revised again in 2018-19, the latest ones. Now they have divided 10 steps into two major categories. Step 1 and 2 indicates critical management procedure. And from step number 3 to 10, the main key clinical practices which should be included at maternity services. So let us go through the steps one by one. Now, step 1 is again divided into 3 parts. 1A says that comply fully with International Code of Marketing of Breast Milk Substitutes and relevant World Health Assembly resolutions. 1B says have a written breastfeeding infant feeding policy that is routinely communicated to staff and parents. And C, establish ongoing monitoring and data management systems, without which we will not be able to evaluate what is exactly going on, or we are improvising on the things or not. So what is the problem is there is always a difference of opinion. So there should be some standard hospital policies. One specialist will say something, the administrator will decide something else. So we should all talk in one language. Next, sir. And that is why we have to come up with the common hospital policy and comply with International Code of Marketing of Breast Milk Substitutes too. Sir, next. So we have to hospitals support mothers to breastfeed by not promoting infant formula, bottles or teats, that's International Code of Marketing. Then making breastfeeding core standard practice and keeping the track of support of breastfeeding. International Code of Marketing was came into picture from 1981. WHO, it is also called as WHO code. So what is prohibited advertising formula directly to consumers, distributing free formula, promotion of formula in healthcare facilities, and accepting personal samples of infant formula and other gifts. Also, idealizing artificial feeding in picture or in marketing of artificial feeding devices. This would include bottles and all the other things, feeding devices. Next, sir. Now, to comply this policy, we have to have a trained staff. So second step tells us to ensure that staff have sufficient knowledge, competence, and skills to support breastfeeding. So what happens is there is a huge gap in knowledge of staff. It has to be updated also. And breastfeeding is a totally different science, a totally different specialty, which has to be learned. So a separate training should be given. So minimum we call 18 hours, 3 hours of supervised clinical training is required. So training of staff on supporting mothers to breastfeed and assessing health workers' knowledge and skills. This is very important. New staff coming or after few years, new improvisations are coming. Science is changing. So we need to be updated. So this is an ongoing process. We should continue. So in today's scenario, whether or not the mother or baby has suspected, probable, or confirmed COVID-19, the health facility staff must ensure that we have to feed the baby as per the standard infant and young child feeding guidelines while taking previously mentioned hygiene precautions. We all are aware of about it. So pre-delivery and post-delivery breastfeeding counseling should be given, and especially telling about this situation, and not to promote breast milk substitutes and feeding bottles in this. Next, sir. So step number 3 says discuss the importance and management of breastfeeding with pregnant women and their families, which is very important to involve family members, as there is lack of knowledge in would-be mother and their kids. Even if only mother attends antenatal sessions, it is not useful. She has to get the family members' support. So family members should be included in antenatal sessions. Usually we conduct this in the beginning of the third trimester, that is 7 months of pregnancy. And we call family members about, the session is about 45 to 50 minutes. So all the information necessary to prepare the mother for having no difficulties and problems after the delivery for breastfeeding, this plays a very vital role. Antenatal session builds the confidence of the mother. She knows what is to be done. So this is a very important thing to be done, step to be followed. Now, in today's, yes, we can also make use of Shishu Poshan app, which can be easily uh, promoted in this, and BPNI Maharashtra website also they can go through. So online they can go through these things, because physically nowadays it is not possible in this situation. Shishu Poshan app page is shown on the picture. Next, sir. Yes, this is our website, which is newly launched. It gives all the information needed. Next, sir. And simple tips, like what type of clothes should mother have after the delivery, full front open, a simple thing which helps breastfeeding comfortable is very important. Next. So now for COVID situation again, pregnant mothers to take same precautions as the other people, respiratory hygiene, avoid crowded places, wear mask, wash hands, and all these we have been hearing for so many days. We can go to next. So there is no evidence that pregnant mothers are at high risk of severe illness with COVID. So report to doctor if any other respiratory symptoms. Next. So it's unlikely, but newborn susceptible to person spread. If baby is infected, transmission we should know either it is before birth or after birth. So Virus is not detected till now. There is no research in amniotic fluid or in breast milk or other fluids. Next. Now, these protocols differ from hospital to hospital, where each and every pregnant mother is tested or with symptoms she is tested or whatever. Step number 4, facilitate immediate and uninterrupted skin-to-skin contact and support mother to initiate breastfeeding as soon as possible after birth. Now, there are 2-3 things important here. Skin-to-skin contact immediately after birth, and to continue this skin-to-skin contact till the baby finishes first feed. This is also very important. So usually in today's situation, mother and baby are separated. It should not happen. We should follow the same guidelines. Next. So the solution is breast crawl, and it can also happen. We can give the skin to skin contact after C-section. Also, there are different positions and ways to do it. Next, sir. So again, important message to remember that same guidelines should be followed as for the normal babies, with precautions, of course, in today's COVID situation. Next, sir. We'll move on to step number 5. Support mothers to initiate and maintain breastfeeding and manage common difficulties. So there are various difficulties and doubts which mother faces after delivery. The first one, next we'll see, commonest one, if she had sore nipples, what she can do. So she should be aware what is next, sir. What is proper attachment of the baby to the breast, which will not create this type of injury. Mother should be informed about all these different positions and actually practically shown after delivery. Next, sir. There is a myth. Next, we can see mother is feeding lying down also. So there is a myth that she should not feed in lying down position, which is not possible after C-section or even after a normal delivery when mother is tired all 24 hours sitting and feeding the baby. So side lying position, or she can also lie back or lie on the back and feed the baby. Next, sir. So she should be shown different positions as per the requirement. The football position after C-section, the baby can be put over the shoulders. So sometimes mother experiences engorgement of breast, then this is not treated at time. It can lead to mastitis and then lastly to abscess. So to avoid all these complications, practical we can show how to express milk time and on whenever she feels her breasts are too much of full and giving pain and heaviness. Next, sir. So you can go through these steps later on. Next. Again, if the breastfeeding mother has symptoms of COVID-19 in today's situation, early medical care, yes. Using mask whenever she is near the child. Next. Cover nose, mouth with handkerchief, tissue while sneezing, coughing, and wash hands for at least 20 seconds with soap and water after coughing, sneezing, before and after every contact with the baby. And routinely clean, disinfect surfaces which she has touched by cleaning with soap or alcohol-based sanitizer. Next. Now, if mother is too unwell to breastfeed, she just cannot feed the baby, then continue to express breast milk and feed the baby. Relactation after illness if she has stopped for a few days, and donor human milk if required during and after illness should be preferred first. So mother chooses to express breast milk, proper hygienic precautions should be taken, cleanliness should be kept. Next. And somebody else like father or grandmother of the baby can cup feed the expressed breast milk to the baby. Step number 6, do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. Now, all the prelactials like sugar, water, honey, as you all know, are aware, should be avoided totally. Next, as there is a risk of infection, decrease in eagerness to suckle at the breast. First and subsequent breastfeeds may be delayed, and future there may be breastfeeding failure. Next. So mother says she has less milk in the initial stage. Obviously, if you can just see, few drops of colostrum are going to be secreted in first few days, but they are appropriate according to the baby's stomach capacity. As you can see in this slide, that day one it is just 5 to 7 ml capacity of the baby, which slowly increases over a week, and then mother starts getting the milk also. So this small quantity is enough to meet baby's needs, and baby gets all the benefits of colostrum too. Immunity booster nowadays in COVID situation, most important, the first vaccine provided, natural vaccine provided in the form of colostrum. Next. So the problem in initial days, mother can say that baby just keeps on sleeping for most of the time. Then we should know how to wake up a sleeping baby. First, remove the clothes. Just gentle touch, just give skin to skin contact, and you can change the diaper if it is wet, and gently massage on her palms, feet, like that sensitive parts on the skin back, and she'll slowly wake up. So every mother should know this skill of how to wake up slowly. Baby should not start crying immediately. We should not just tickle her vigorously on her feet or something like that. It should be a very slow and pleasant experience for the baby. Slowly the baby will arise, and then she can put her to breast. Next, sir. So how the mother will assess that her milk is sufficient for the baby or not? Because this question is query is coming in her mind, doubt is always there. So she should always look for the wet diapers and number of stools per day. As you can see, it goes on increasing as it goes on to one. By the end of 1 week, baby should be passing at least minimum 6 times urine in 24 hours. And slowly you can see the color of the stool also changes. So by 7 to 8 days, it should be yellow curd like stool, slowly changing the color. And the third criteria, initially the weight. Initially, there is a weight loss up to 7 to 8% of birth weight is just normal. It should be achieved maximum by day 12, the birth weight, or latest by day 15. And approximately the baby should gain 500 grams minimum per month till 6 months, till she is exclusively breastfed. So these are the three mantras every mother should know before leaving the hospital, that she should keep an eye on urine output, stool output, and how is the baby's weight going on. Every time she visits the doctor, we can also have a look at the growth chart. How is it going? If you can zoom it, then we will be able to see initially there is a loss, and by day 2 weeks, baby should be able to regain the weight back to the birth weight and then start increasing. Next, we move on to step 7, which says enable mothers and their infants to remain together and to practice rooming in 24 hours a day. So an arrangement is done letting mothers and babies stay together, and even if the baby is sick. Now this allows, yes, even in COVID situation, please remember that mother and baby can be kept in one room. If not on the same bed, but in one room, one relative can be attending to the baby, and whenever she needs to be breastfed with all the precautions, mother can breastfeed the baby as and when required. So she can put the mask whenever she is handling the baby. She should wash her hands and all the other precautions, hygiene precautions, respiratory hygiene, etc. Next. Step number 8, support mothers to recognize and respond to their infants' cues for feeding. Previously, they were using the word demand feeding, but now it has been changed to infants' cues feeding. What is it? Baby shows some hunger cues. Next slide, and we'll go back to these slides again. Okay, you can nicely see in these pictures, baby is searching for the breast, turning the head to one or the other side, rapid eye movements, becoming restless, making some sounds, suckling sounds, or putting the fingers into the mouth, suckling movements of the mouth. Next. Yes, and crying is the last feeding cue we should remember. Whenever we'll ask mother that how do you know that baby is hungry, she'll immediately say, oh, when the baby will cry. But we should let her know that crying is the last hunger cue. After the baby starts crying, she is not interested in feeding. So we should look for these hunger cues first and then feed the baby. Step number 9, counseling mothers on the use and risks of feeding bottles, teats, and pacifiers. So we have to counsel mothers, see these are the effects, and you have to decide whether to use them or not. So in short, we have to follow IMS Act, which sir has nicely explained. So giving bottle creates a nipple confusion, chances of infection increase a lot. So always use cup, spoon, or katori as a substitute if we need to, and explain the risk of use of teats and pacifiers. So always there is a problem that is my milk enough? So newborns usually, oh, this is the previous slide which has come, I think. Okay. So step number 10, the last step we are coming to, coordinate discharge so that parents and their infants have timely access to ongoing support and care. So just taking care at the hospital level will not be sufficient. Mother has to be followed. After she goes home, she may have so many problems. So then whom to she can approach? So referring mothers to community resources for breastfeeding support is very important, and working with communities to improve breastfeeding practices also. So we can have some written discharge guidelines. Mother support groups can help for continued care and timely access facilities for mothers and families. So in short, we can conclude antenatal preparedness, support during hospital stay, practical help for individual problems of mother, motivate the mother, continue education, and give her emotional support or counseling the mother, and sustained efforts from all. So you can see first all the list given except the last, or including the last. The role of mother support group leaders is vital, and she is involved in all the steps. So this is in short a process how we can get as baby friendly certified. To fill a self-assessment form first. So there would be a first visit, then a small training workshop for health staff. There would be interviews taken, mother, nurses, and doctors, and taking a round, assessment of written material, and fill up the form by assessor. So suggest some changes we need to be changed. Certify as certificate of commitment. You're committing that you would make these changes. So after second visit, again interview with mothers and staff, and then give the final certificate. So I thank Dr. Prashant Gangal, Dr. Reshmi Neugi, and others for the slides. And you can just play the video on the last. So if we deliver at the baby-friendly hospital, we can have these happy mothers and healthy children like that. Thank you so much.
Thank you, Dr. Sarita Bhagwat, for your wonderful and very thought-provoking presentation. And in fact, I would urge all the medical professionals present here, as well as the media and other civil societies present here, that we should strive There is currently a program called Ma Mother's Absolute Affection going on
Yes, sir.
across the country, which basically brings back the focus on BFHI. And I would urge each and all medical professionals associated with promoting infant and young child feeding practices to kindly focus on this, because as there are several slogans, and one of them is that the breastfeeding is the best feeding for the child. I would pick this up. Moving on, we now have Dr. Praveen Kumar with us. Dr. Praveen Kumar is a Director, Professor of Pediatrics, Lady Hardinge Medical College and Associated Kalavati Saran Children's Hospital. He is the Secretary, Pediatric and Adolescent Nutrition Society. It is basically an IAP nutrition subspecialty. His special interest lies in pediatric gastroenterology, hepatology and nutrition, infectious diseases and pediatric HIV. He has immense contribution in national child health programs like development of training package on facility-based management of children with severe acute malnutrition and facility-based IMNCI. He is the resource person for national and international training for health workers on IMNCI, facility-based management of children with severe acute malnutrition, community-based management of children with severe acute malnutrition, and infant and young child feeding. Dr. Kumar has over 74 publications, including 6 chapters written in various books and research papers and reports numbering 47. So I would now request Dr. Praveen to kindly share his presentation with the group and explain us his points. Over to you, sir. Thank you.
Okay, so thank you, Saurav, for kind introduction. I just wanted to check with you how much time do I have, because we are running late. It's already 12:20. So can you just please confirm how much time I have for this presentation?
Sir, you would have around 10 minutes. 10 to 15 minutes, sir. Sir, do I need to project the slides?
No,
Okay.
I'm just.
Thank you. Thank you, sir. Thank you so much.
Okay, so thank you very much. And although it was a 20-minute presentation, so I will try to finish in 15 minutes as advised by organizers. So thank you. We do know for healthy community, if we have to have a healthy community, our children are most important, and healthy children ultimately is important for healthy community. And for healthy children, they should have good nutritional status of these children. So we are talking about IYCF practices in NRC or community-based management, whether what all we have. So we know severe acute malnutrition is the term when we use if the child's weight for height G-score is less than -3 standard deviation, and or the baby has bilateral pitting edema, and or the child has mid upper arm circumference less than 11.5. Prevalence is really high in India. That is just to highlight that 17% of our under 5 children, they are wasted, and 4.9% of children are severely wasted as per CNNS data. And almost all states, they have high prevalence except for few northeast states. Why we need to identify them early? Because there is a vicious cycle of malnutrition and infection. And if you do not identify them, then there is a risk of these children having higher mortality due to common infections. And that is, we do have evidence of this, that which Saurav initially he was mentioning that severely acute malnourished children usually have higher risk of death as compared to others. And most of time, if you do not see their nutritional status, then the deaths will be looking like this. But if you really determine their nutritional status, then approximately 50% of deaths are occurring, and this is being contributed by malnutrition. It's not only mortality, but if you are not identifying and treating them, then they are also at risk of impaired physical growth, impaired brain development, and they also have increased risk of infection as well. There are so many causes, out of which inadequate feeding practices is one of them, although food security and all other components, household food insecurity, and there are several causes, but one of the important causes is inadequate care and feeding practices. We know we have to treat them, and WHO, Indian Academy of Pediatrics, Government of India, all they have given a protocol for management of these children, because these children, they have several physiological changes in form of reduced physical activity, reduced basal metabolism. They also have lesser inflammatory and immune responses. They do have some changes in sodium potassium form, leading to intracellular movement of sodium and leaking of potassium out of cells. Also, their gut, they have decreased acid and enzyme secretion. They also have venous atrophy, leading to decreased absorption, decreased motility, and bacterial colonization. They also have initially free iron, leading to risk of bacterial growth and free radicals. And they also have lesser organ reservoir, and that makes them susceptible to hypoglycemia if they are not taking feed for longer time. And their heart and kidney also, they are not able to handle if they are given normal fluid like any other normal child. So that leads to a strategy of integrated SAM management, where we have preventive approach by community mobilization with women's group for child nutrition and health, and social behavioral changes for improving child nutrition, promotion of water, sanitation, hygiene, improving food security through public distribution system. However, if the child has already, and these preventive approach has failed, and a child has already become a SAM, he will need therapeutic management, which has two components. One is community-based management of children with severe acute malnutrition, and the other is facility-based management. Both are interlinked in the way if there is a child who is enrolled in community-based management, and if he develops some medical complications, then he is usually referred to facility-based. So these facility-based treatment is known as nutritional rehabilitation center. In that you have in the state of Odisha, also in most of the districts level, you have these nutritional rehabilitation centers. And how do we decide whether this child will be enrolled in community-based or facility-based? That is usually decided by two criteria. One is whether this child has any medical complication, and how is the appetite. If the child has no medical complication, another has good appetite, and that child may be managed in community. And at a given time, 85 to 90% of the SAM children remain managed. While children with poor appetite or medical complication, they will need facilities. So coming to just a summary of this program strategy, which I have talked about, is the center is prevention of acute malnutrition, which is by improving the component which I have already described. And then there should be some routine active screening to identify severe acute malnourished children early. And based on two criteria which I have mentioned, this will decide whether the child will be going to community-based management or facility. So now, what are the how these IYCF practices are key component of this integrated management of SAM? Because management of SAM less than 6 months with prospects of breastfeeding, there is a this management protocol aims to correct feeding by correcting positioning attachment. And if the mother has lesser amount of milk production, then SST with F100 diluted, which is usually practiced. Already we have enough discussion on these factors. So these mothers, they are counseled on the supporting factors of milk production. And also the family is advised there is a time to correct their attachment positioning of the babies when these mothers are admitted in nursing. And this is the amount of EVM or 800 diluted, which is used for SST. This is just to show you the method of SST, which is being used in less than 6 months with less amount of milk. If the mother has, then most of the time this is the way to apply. And also in all NRCs or whether it is a community-based program, this essential nutritional practices, counseling is core component for both NRCs. They do have counseling sessions for mothers, where the most of the time the mothers will be counseled for improving child feeding and caring practices. And this is the flip chart book, which is available in different languages, in different states, which is being used. And what are the main core component? All the mothers, they are advised to continue feeding, breastfeeding. That is always, they are encouraged to continue breastfeeding. Timely introduction of breastfeeding. They are counsel for introduction of complementary feeding. Most of the component already has been covered by previous speakers, so I'm not spending much time here. They are also counsel for increasing food diversity by counseling them importance of different food groups. Yeah, also macronutrient rich complementary food items, which already has been covered. Also, because these children are malnourished, so they are also counseled to increase nutritive value of these food items by certain modification, which they usually also have demonstration in nutritional rehabilitation centers. They are also counseled regarding good hygiene, proper food handling, which is there, and also counseled regarding avoiding junk food after going from these NRCs or when they are enrolled in the CMON program. So this is what they have continued feeding during illnesses also. Just to summarize, severe acute malnutrition prevalence is unacceptably high in India, and inappropriate feeding practices is one of the major cause causing this severe acute malnutrition. Early identification and protocol when based management is recommended for preventing this severe acute malnutrition and improving the overall prevalence. And improving IYC practices is key component of integrated SAM management, both whatever is there in the facility or community. Whoever is interested in knowing more about these activities, they can visit COE SAM network website, which we have, and with this, I stop here. Thank you very much.
Thank you so much, Dr. Praveen Kumar, for sharing your views with us. Now, without wasting my time, may I move over to Dr. Pragya Paramita Giri, and I would request her to basically fill the questions now. The questions, as you can see, if you can open the Q&A box, you can see the questions are there. So over to you, Pragya.
Thank you, Saurabh. So we have many questions, so we'll take up one by one. It is by Sanjay Kumar Sao, who he has asked, often we talk about adequate diet while discussing complementary feeding. My question is how to ensure the quality of complementary feeding among the remote rural community in Indian context. I would request Dr. Prasad Kangal to answer these questions. Over to you, sir.
Yes. We already talked about this question. First thing, we don't have a system in place to teach the mothers how to give good quality food, talking to them about different groups, explaining to them that what substances which are locally available, the foodstuffs which are locally available, the combinations will give rise to this particular quality of food, and monitoring that what they are exactly doing. Just teaching the mother once at end of 6 months is not sufficient, but constantly keeping a watch by group sessions and in the remote rural areas, identifying the common mistakes made in the community. If you follow these particular guidelines, then the adequacy of or quality can be well maintained. Not an easy task, but definitely needs to be done.
Thank you, sir. Another question, so that now it is pre-conception period is giving more importance. So this question I would like to Dr. Praveen Kumar sir to take up this question. So how that stakeholders would be taken into consideration for initiation of breastfeeding, early breastfeeding, and how to prepare the mother in the pre-conception period. Over to you, sir, Praveen sir.
So I think already Saurabh has mentioned, you have a MA program. There are certain deliverables. Already in the initial, also it was highlighted. But already highlighted that although there is an increase in institutional delivery, but still you have early initiation, which is less. So I think already the MA program is talking about the rewards for the institution where you have good practices. And I think, the only thing which is going to work is awareness, and already in MA program you have different components, but only point is it's not being implemented the way it should be. So that is the key message which
Sir, another questions for you, sir. I don't know the name of the who has asked, but how to or what proportion dilute the cow milk for children more than 1 year?
What is the question? Can you repeat it?
How to or at what proportion we can dilute the cow milk for children for more than 1 year?
Right. So I think more than 1 year probably is not, and I think why I do understand why this question is coming, because of the WHO guideline where they usually tell you that cow milk, if you use, there is increased renal solute load, and it should not be used. But see, we try to look for scientific evidence, and most of time, the ideal is that they should continue breast milk and up to 2 years. And if the baby is getting breast milk, they don't need any cow milk from outside, because they are getting. So what you need is complementary food item and the quality which Dr. Prasad has already mentioned. So they need food item. But wherever there is breastfeeding is not there, they have to use cow milk. We tell them to use cow milk without dilution, because in our country the problem is whenever you talk about adding or diluting, they always over dilute, and we are having problem due to this. Second, we have last year we have a publication in 2019 where not in normal population, in HIV setting. We don't see so much a problem which usually WHO recommendation is there. And if you go by your IMNCI guideline also of the country guideline, they tell you to give without, either you can give the dairy toned milk or fresh animal milk, that also without dilution. But then you will have to give them water. In addition, you should give water separately. So that you do not have much increase in rhinocell.
Sir, another questions in this context by Dr. Madhav Naik. He has asked bovine milk from cows associated with type 1 diabetes, as in Nelson Pediatrics book he has mentioned. If in any case, mother milk is not sufficiently produced, even after counseling, what is the best alternative option for this case?
So I think let Dr. Prasant answer first. I think because he is working in this field, and I will definitely put my opinion. But let Dr. Prasant first give his opinion on this.
See, adequate attention should be done for preventive measures and to help the mothers to see to it that they provide breast milk to the baby. Yes, but there are situations where, in spite of all possible expert help, the baby, the mothers need something extra, but babies need something extra. And in such situations, unfortunately, I would say that below 6 months, though costly, the formula has been recommended by WHO and UNICEF before 6 months. The fresh milk, bovine milk cannot be given to the babies. So in such cases, the whatever available local formula and which is the lowest cost can be offered to the baby, but with proper precautions. But again, as I would say that appropriate counseling of the mother before we counsel her on the formula needs to be done. The method to be fed by Vati spoon, that also has to be seen. Beyond 6 months, it becomes a little dicey because the bovine milk can be used. And as Dr. Praveen Kumar has said, we don't need any dilution. Sometimes we ask them to make it sweet with sugar or jaggery, but extra sugar, etc., has to be avoided. And of course, the stress is on food beyond 6 months, not on milk.
Okay, so I just wanted to add, ma'am, because I thought, if you go by national IYCF guideline, so in situation where breastfeeding, suppose the mother is not there, adopted baby, some of the conditions where it is justified, or you have, that guideline mention you 3-4 no options. So first is we should explore the possibility of donor human milk if that is available, right? Or the weight nursing, that is the ideal one. But if suppose that is also not possible, then the option, as sir has already highlighted, if you go by evidence, then probably all the developed countries, they will mention infant formula better than the fresh animal milk. But in our country and most of the neonatal or most of the hospital, we do advise them to use toned milk, dairy milk or fresh animal milk. But the only additional point is we have to supplement them with micronutrients. Which one to prefer, that will be decided by the suitability of that particular condition. So you will have to talk to family and you will have to try to see which is most suitable for that family. But be sure that you have to advise them not to use bottle. Second, the hygiene, you will have to teach them how to prepare it with lot of care, hygiene, because that will require a lot of family support and other things also. So that should be taken care when we are.
Thank you, sir. Another questions by Baisali Goel. What is SSTF 100 diluted for children below 6 months of age?
Okay, so SST is nothing but this is supplementary suckling technique, which I have shown. So what happens if the mother is not having adequate? So what you do in this SST, you give them F100 diluted, which we use in nutritional rehabilitation center. So if you give through a feeding tube and the baby will suckle at the breast, that will stimulate prolactin and there will be increased milk production. So that is the science behind this whole SST process. Because you will have to give some milk So that's the reason we are giving this F100D in nutritional dairy.
Thank you, sir. Another question is from Dr. Alpana Misra. She has asked, how can we get the certificate for BHFI? This question may be asked answered by Dr. Sarita. Sarita ma'am.
Hello, can you
Yes,
hear
ma'am.
me?
Yes.
Yes. As it was shown on the slide that you have to assess first, and then the workshop will be done to train the health staff. Then the reassessment would be there. So as of now, BPN at Delhi is authorized. Even we have BPN Maharashtra have a team to do this, and we have assessed almost 27 municipal hospitals in Mumbai and 37 NICU with NICU facility all over Maharashtra district. So we can have BFHI workshop first at your facility and then think about it.
Thank you. Thank you, ma'am. Another question is, when we have multiple births, like twin or triplet or quadruplet, how we are going to manage the breastfeeding? This question is by Dr. Sanjay Kumar sir.
Yes, triplets and quadruplets is very, very rare. So let us talk about twins, which is now common after using IVF methods and all that, right? So particularly for twins, we make sure that mother develops the skill of feeding both the babies together at a time, simultaneously, as it was shown in the picture, twin feeding food in football position. So it becomes much, much easier and relaxing for the mother if they feed at one time, then wake up at one time, and she can take a rest in between and all that. But all she can keep on expressing milk also. So whenever she wants to take rest, it can be helpful. So a lot of support from family members is needed.
Thank you, ma'am.
But she can easily feed twin babies. Yes,
can
sir.
I just add to that?
Yes.
Okay. Quite a few times the twins are born premature, they are born low birth weight, they may need NICU help and care. In such situations, it is very important to start expressing the milk and pumping out the milk at least 8 times in 24 hours very early on. Because the calibration of breast milk supply occurs around day 11. And if the babies are in NICU and the mother is not emptying the breast, the final volume what is required is not achieved. So in these cases, achieving calibration by day 11, even taking help of the breast pumps, etc., would be really helpful in establishing the milk supply. The motivation of the whole family along with the mother required is definitely a tough job.
Thank you, sir. Another question is by Pragya Paramita Das, but I think sir has already discussed. Is it necessary to clean the breast of COVID positive mother before every time she feeds?
No, that is not necessary. Normal standard hygienic precaution may be bath once or 2 times a day, and of course, quite a few times when we cough, the cough goes down, onto the lower upper trunk. So avoiding direct coughing, etc., wearing mask should be good enough, and routine standard hygienic precautions. Expecting a mother to clean up every time before she feeds is not feasible, and that is not required also. One more thing I would like to point out, that when the mother has no symptoms of any illness, no cough, cold, no COVID negative, mother is absolutely normal. And when she's in the house with the baby, she doesn't have to wear the mask. Because I have found that many mothers, even at home while feeding the baby, caring for the baby, to the extent they're not kissing the babies at all or not giving skin to skin contact, that is wrong. Only if the mother has symptoms like cough and cold or some illness, whether proved or unproved, that she will have to use mask. Of course, when she's out with the baby, she will be wearing mask as general standardized precaution. The family members again have to be careful, because in the house, only if a particular the member has cough and cold, she avoid any contact with the baby and the mother altogether.
Thank you, sir. Dr. Sanjay Kumar sir was emphasized that twin cases is all right, but what will happen to a mother who has quadruplet?
Am I supposed to answer the question?
Yes, sir. Yes.
Okay. Twins are again. What we say is that if a normal mother produces about 750 to 800 ml of milk a twins mother will produce something like 1400, 1500 ml of milk. But if we go to the situation to triplets and quadruplets, this multiplication may not occur, in that proportion and extent. So as Dr. Praveen Kumar had said, that in such babies, we should definitely look for alternative of milk bank milk, pasteurized milk available, look for the options of wet nursing. And after the end of it also, the hunger of the babies cannot be met in spite of mother and the family trying everything. Then we'll have to go to train the mother to how to use a formula, how to you feed without using the bottles, and at the same time give the advantage of breastfeeding in rotation to all the babies. It cannot be said that only two babies should be fed breast milk and the two babies should be, or one baby should be given outside milk. The benefit of immunity which comes from mother's milk should be given to all the babies, and every effort should be made to increase mother's milk supply to the maximum. Especially calibration by daily is important. Again, it's not just about breast milk and breastfeeding. The caring of the baby also becomes difficult as the number of babies increase. So more number of not the mothers who are the people who can care for the baby have to be enrolled in, and that extra care also is important, not just feeding.
Thank you, sir. I think all other questions are very similar that were already answered. So we won't take up.
Pragya, just one question. I
Yeah.
think Olivia had asked, Oliva Patra, that was the first question. Can we do something to replace the palm oils in biscuits, which are most of the time consumed by children? So maybe Dr. Prashant, you would like to take this question, whether biscuits should be an option.
I think you can answer that question.
No, I mean, biscuits is not generally an option because that is not something we prescribe for young children specifically, because it is full of empty calories, and because it's made of maida and all those kind of things, and there are elements, emulsifiers, etc., which are added, which are not really required for the child. So what we prescribe for the child is basically look at freshly prepared home-based kind of foods, which are not excessively sugary or excessively salty. Those are the two things, and not highly fried, deep fried. So these are the kind of things we request to avoid for the children. Sir, would you like to add anything?
What I would suggest is that, as I see in this particular meeting, the uncommon questions are being asked more. And I think we need to focus on common mothers and common babies, normal mothers and normal babies, where the exclusive breastfeeding and early initiation and good complementary foods. The rare situations are really rare. And for such situations, the answers are also difficult. And not only the answers are difficult, they are form a very drop in the ocean. So we must think more of common normal mothers and normal babies, and how breastfeeding and complementary feed can go well with this particular population, which is almost 90 to 95%.
Dr. Pragya, did we take the question on mixed feeding, because that is also very critical in terms of.
Okay. Dr. Gitismita Nayak has asked, what about mixed feeding? Over to Prasant sir.
Mixed feeding in a which situation? You are asking about HIV and mixed feeding, I believe.
Yeah, I believe.
Okay. See, mixed feeding is not recommended in HIV base for simple reason that breast milk provides something like a protective cover to the intestines where HIV germs are prevented from entering. But when mixed feeding is done, this particular barrier is broken, and the chances that the virus in the breast milk can travel easily into baby's body and cause infection. So mixed feeding definitely is not recommended in HIV situation. It is more exclusive breastfeeding even in our country as a default, whether mother is HIV positive or not. And therefore mixed feeding should be strictly avoided in HIV situation, because that increases the chances of transmission through breast milk.
Okay.
So, can I come in here? I just wanted to add this.
Please,
so, as sir has rightly described this mixed feeding for HIV, but there is certain changes, and WHO has revised this guideline in 2016. And as per the revised guideline, if the mother is on ART and if she is compliant, so please remember this, I'm not This is not a general statement. If the mother is on ART and she is compliant, so this if she has to join or some other, so this should not be a criteria for stopping breastfeeding, mixed feeding. So the meaning is that if mother is compliant taking ART and you have control virus, so you can allow her to continue mixed feeding if she is compliant to this. So this is the recent change in the guideline which is there in WHO, provided she is on ART and compliant. So this is the change which is there.
Okay. Thank you. Thank you so much. Thank you so much. I think this brings us to the end of this webinar. Now, before I request Pragya to give the vote of thanks, may I request Gautam to quickly launch. So Pragya, would you like the poll to be launched now or after the vote of thanks?
Now it will be fine.
Okay. So Gautam, if you can please launch the poll. So people will answer the poll. It will take very short time and then we will get into the vote of thanks.
Thank you. Saurabh, can you take one question more during this whole period?
Yeah, sure.
So Dr. Somin has asked whether this 6 months of maternity leave is sufficient for promoting exclusive breastfeeding or we need more. So we can ask Prasant sir or Praveen sir to take up this question.
You want me to answer?
Yes, Dr. Praveen, please.
So I think that will depend. At this point of time, you have 6 months of maternity leave, but still it is important to have this in all settings at this point of time, which we do not have. Definitely, we we can't say to increase this, and I think we also the mothers, they have child care leave for those exceptional no issues. If they are not able to manage, so they can always use this child care leave which they have. So I think 6 months is at this point of time, we feel is fine, provided it is implemented across all the settings.
Can I add a little bit?
Yes, please.
Okay. 6 months, as Dr. Praveen Kumar said, is not widely still being followed. So that is the first goal that we need to achieve. But beyond that, if we can stretch further to 1 or 2 months more, then mother can adjust the baby to complementary food. So when she's out, she can use express milk, and the family members also can feed this milk as well as give complementary food. So whenever the opportunity arises in our private clinics, we request them to give 6 months for exclusive breastfeeding, extend 1 or 2 months more for giving complementary food till the time baby gets adjusted to food, especially in cases where the baby is low birth weight or and needs some extra care. But yes, with the 6 months mark has to be achieved first, then we can hope for maybe extension for 1 or 2 months more.
Thank you, sir. Over to Saurabh. We can wind up now.
Okay. Thank you, Pragya Paramita. The 30 out of 70 participants have responded. While people keep on responding, may I now request Pragya Chaudhary to kindly deliver the vote of thanks. Over to you, Pragya.
Thank you, sir. It's really a privilege for me to give thanks to these eminent speakers in this webinar series of webinars. So this is a kind of ceremony which we all do in all kinds of workshops and these webinars nowadays. So my heartily thanks to our speakers, our eminent speakers from who are nationally very renowned for their technical know-hows and their technical expertise, who has given their consent in one go to enlighten us with their highly technical expertise. And in this light, I would like to thank Dr. Prasant Gangal, who enriched our knowledge on infant and young child feeding during COVID-19, focusing on the right kind of complementary feeding which can be given to the young children, along with the how we can avoid to the Infant Milk Substitute Act. Very nicely elaborated. And I would also like to thank Dr. Sarita Bhagwat, who nicely elaborated us regarding our BFHI, Baby Friendly Hospital Initiatives, the 10 steps, which I think all the medical fraternities who have attended this webinar can practice in their day-to-day clinics and make their clinics baby-friendly hospital. And in this pandemic situation, how these baby-friendly hospital initiatives can be more practiced in the settings. And our Dr. Praveen Kumar, who has highlighted the importance of infant feeding practices in management of severe acute malnutrition among the young children. Thank you, sir. And Vinod Kumar Patra, who addressed the participants on what is the importance of infant feeding practices and what and in the during the current situation we must achieve more than 90% or 100% of breastfeeding practices, but we are lagging much more behind. But in comparison to India, Odisha is doing better, but still we have to go a long way. And I would like to convey my heartful gratitude to our director, Madam, Director AIMS, Dr. Gitanjali Padmanabhan, who is always a support in doing any such workshop in our CPHN cell, which is a part of Department of CFM AIMS Bhubaneswar. Would also like to thank Saurav Bhattacharya, who is not only a supporter but continuously given his hands for support to conduct any such kind of activities and this series of webinars on the thematic topics. Would also convey my heartily thanks to Dr. Pragya Giri and Dr. Soam Pragya Parida, without whose support this webinar would not have been very a success. And most importantly, our participants from different medical fraternities, AIMS, Bhubaneswar, and medical whose support means without whose participation, this would not have been a success. So in this light also thank our RCPHN team, which includes our Jasmine, Kasturi, Sanjita, and Sonali in making it a great success. And also thank the media persons who all attended the webinar and covering the subjects related to IVCF in their uh, dailies. Thank you. Thank you all. Thank you, sir.
Thank you, Pragya and the RCPHN team. We are now ending the polling. So we have around 39 who have responded. We are ending the poll questions. So thank you all, and we end here. Over.
Thank you.
Gautam? Gautam?
ଆଜ୍ଞା
ଏ ଯୋଉ poll ର ଯୋଉ results ଟା ଅଛି,
ହୁଁ
poll ର results ଟା ଟିକେ ଆସିଯିବ ନା, share କରିହବ ତ?
ହଁ ଏଇଠି ଗୋଟେ ଅଛି ଡାଇରେକ୍ଟ ସେୟାର ରେଜଲ୍ଟ ଅଛି
ନା
କରିଦେବି
share result ତ ସେଟା screen କୁ
ସମସ୍ତେ
ଯିବ ନା?
ଦେଖିଥିବେ ବୋଧେ ହଁ ହଁ
ହଁ
ହଁ
ମତେ
ଥିବ ଆର ଏଇଟା ସରିଲା ପରେ ବୋଧେ ମୋତେ ଦବ ଅପସନ୍
ଠିକ ଅଛି. So you close this webinar
ହଁ
and
ବନ୍ଦ
close.
କରିଦେଉଛି ହଁ
Thank you.
ଥ୍ୟାଙ୍କ ୟୁ